In this module, we're going to look at a couple different aspects that I want you to be prepared for as you start to enter the workforce. Regarding, you're going to see shortage, you're going to see turnover, you're going to see burnout. And I want to give you a couple different points of perspective to kind of understand what's going on or get a little bit better understanding of what's going on and how you, in your administrative, supervisory, managerial role, can kind of mitigate what's happening to your employees or to your team. So we'll start off, like we always do, just going over the objectives. Won't go over each of these in detail, but just there for you to look at and give you our agenda for today. So you can see we're going to start off with shortage, work our way into talking a little bit about burnout, and then finish up with some key points. So before we can start talking about workforce shortage, burnout, things like that, and what we can do from an administrative standpoint, we have to first understand kind of where we're at right now or what's our current state. And we all know, and you know from many of the classes that you've been in, I'm sure you've heard this said over and over, we're expecting a huge shortage of healthcare workers, and unfortunately it's going to become a substantial shortage that we're experiencing. So you can see there on the left, kind of have a chart by discipline, and then by 2025 what we expect the shortage to be. Now, as of right now, the last time I was able to pull data, we have about a turnover rate across the industry of about 16.5%. But understand too, for every 1% that turnover rate increases, so if it moves up to 17.5%, we're adding an additional $359,000, almost $360,000 to our bottom line in cost just in turnover. So for each 1% increase, we're adding about $360,000. Now, we know nurses and the nursing discipline make up the majority of our workforce in healthcare. They are a huge majority, especially when you get into the hospital acute care setting. Realize too, we don't want to see turnover, and we want to do what we can to decrease the amount of turnover that we see, particularly with our clinical staff. If you look at it from a nursing perspective, it's estimated that for every one nurse that quits, or for every one nurse turnover that you have, you're adding about $63,000 at the higher end to your bottom line costs. So it's costing you as an organization, you as a department, about $63,000 when a nurse leaves your organization. And that's due to the training that they take with them, the training that you will have to put into hiring that new nurse, getting them accustomed to the system, the classes that you have to send them to, all different aspects like that. So it's just a couple things to think about. And then you may have noticed there at the bottom, I put in a little section about turnover in regards to public health workers. And we're expecting that shortage to reach about 250,000 by 2020, which is not too far away in the grand scheme of things. So just a couple things to think about in terms of where we are currently in the environment. So now that we can kind of have a base knowledge of where we're at, we have to understand how did we get there and how did we get to the point we're at right now. And it's really, we see this kind of cross-section of two trends that's created the perfect storm of what we saw on the previous slide. And that is, we have this increasing demand of care, but the current supply of caregivers that we have are not able to keep up with the demand. And it's going to get, unfortunately, even worse, as we saw on the previous slide, with the projected shortages we have coming over the next couple of years. So we'll take this in two sections and look at increasing demand as that first kind of cause, and then we'll move into the supply of caregivers and talk about why that is a cause of the shortage. And again, this is stuff we've kind of reiterated throughout several courses that you've been in, but just want to put it up here again to kind of tie everything together. In terms of increasing demand, we have that shifting patient population. We have a lot more baby boomers retiring. By 2030, we're expecting 20% of our population to be 65 or older, which is a huge majority. Considering that typically 65 plus tend to use about twice as many resources from a healthcare perspective as the general population. So that's going to continue to put a strain on those working in healthcare right now. And overall, we see this population growth. Not only do we have a shift, but now we're seeing a population growth, which is going to lead to about a 27% increase in demand for healthcare services. Another point to think about too with increasing demand, particularly from our older generation, our baby boomers, we have a lot of chronic diseases, chronic conditions out there, and even by 2030, it's estimated that we're going to see about half the population with at least one chronic condition, if not more, and that's from the National Center for Healthcare Statistics, has kind of projected that out. And if we look at patients who do have some type of chronic condition, they're likely going to use 2 times more physician visits per year than the average population. So couple that with what we just saw on this previous slide here, with 65 plus already using twice as many resources as other sectors of the population. Now couple that with patients who have chronic diseases and chronic conditions using twice as many physician visits per year than the rest of the population. So we can kind of start to see how this demand is starting to weigh down on our caregivers and the supply of caregivers, because we have that kind of, like we said, that cross-section of increasing demand crossing with our shortage of caregivers, and caregivers not able to keep up with that increase in demand. So a couple figures I'm going to use here may look familiar from other classes that you've taken, but they're still relevant, and so I felt it would be good to kind of tie those classes back in and use this information again. Now when we move from the increasing demand into the supply of caregivers, we stand within, probably the next, we'll average it out to 7 years, we're going to be losing a pretty big portion of our caregivers, and mainly that's going to be due to retirement. So if you think of it from the physician end, we're going to have a lot of physicians reaching that retirement age or trying to get out of the business altogether, and so that's gonna even cause this kind of supply of demand, or supply of caregivers, to decrease while we see our demand increasing. As we said, physicians, a third of those active physicians right now, well, as of in 2008, so this is almost 10 years ago, are 55 plus. So those 10 years ago that were active physicians, they're reaching or are already at retirement age now. Same with nurses. We had 36% estimated by 2015, which was the last time I was able to find data for this, are going to be getting to that retirement age. They're going to be between 50 and 65 years old, so they're going to be in that prime retirement age. We see just kind of all of these factors coming together to create this perfect storm. We've talked about in other classes, particularly in health systems, if you were in that class, about our flat medical school attendance. The graduation has remained flat over the last couple of years, and we've only been graduating about 16,000 physicians per year, which sounds like a lot, but in the grand scheme of things, when you think about our supply and demand, it's not that many, and this is mainly due to the cost of education and the rising cost of education. We have a lot of potential students who want to be physicians, but simply can't afford to go to medical school. Now, that doesn't mean they don't enter into the healthcare workforce, but they may enter it in different roles, such as physician assistants or nurse practitioners. And depending on what state you go in, even though we may have a good supply of those two disciplines, they still have to practice under a physician. And with a flat medical school attendance, we may not have enough spots open for PAs and NPs to practice under a physician. And like we talked about in other classes, this declining, interest that we see in primary care, where the majority of well, not the majority, but a large part of our population live in that primary care shortage area. Now, looking at overall job satisfaction, and we'll get into this in a little bit more detail on the next couple of slides, but physicians, for the most part, are experiencing some job dissatisfaction, mainly due to overall working conditions. And what I mean by that is a lot of physicians have just decided that there are too many challenges to run their own business or run their own practice, and the benefits are not outweighing the risks for them. So they are turning away from private practice and trying to enter employment with hospitals and health systems, and turning away from more of these private practice setups that we have. Now, when we look at RNs, which are registered nurses, or NPs, nurse practitioners, think about this for a second from this perspective too. We know that nurses make up the majority of our staff and our employees, especially in an acute care setting. But we have College of Nursing across the country in 2014 denied almost 70,000 applicants which were completely qualified to their program, and that's on the undergraduate and the graduate level, simply due to not enough staff, or we don't have enough clinical sites, which some of you may be familiar with. If you're trying to find an internship here, or you've tried to find an organization to do a past project with, it can be difficult because we're competing with nurses to have our sites. As students, we're competing with respiratory therapy, we're competing with physical therapy, we're competing with nutrition, we're competing with all these different disciplines here within our own college. So you can see, why a lot of College of Nursing would deny, completely qualified applicants. They just simply do not have enough space or budget to accommodate those students. So it's a growing trend that's a little unsettling, that's starting to emerge. And even too, looking at regional disparities, so we can see for every one position we have in an underserved area, we have about 4 that practice in an area that has probably more than enough. So a 1-to-4 ratio there. And even look at the difference in Mississippi and Massachusetts. So we have 174 physicians per 100,000 people in Mississippi, and 405 physicians per 100,000 residents in Massachusetts. So you can start to see that shift and that differential between these two very different regional or regions across the United States, and we see that everything is not really evened out and equitable like what we would like to see. So what does all this mean, and kind of what are we trying to get to with this particular module? When you get out in the workforce, I can guarantee you're going to experience, either yourself or with your team or your employees, some type or level of burnout. And how we're kind of defining burnout here, you can almost spot it because your employees are going to kind of have these dulled emotions. They're going to be really detached, and some may even have this kind of sense of hopelessness. But burnout can ultimately lead to turnover, which is something, we talked about at the very beginning of the module, that we want to try and stop if we can, because it is so expensive to us as an organization. So we're going to talk about a couple more things that lead to burnout, and a couple of things that you can do from an administrative standpoint to kind of manage your team through this burnout cycle that you're inevitably going to see at one point in your career or another when you start getting out in the workforce. So let's suppose for a second, just imagine that you have achieved your dream job and now you're the CEO of a hospital. And you're out doing your rounds one day, walking around the facility, checking on things, seeing how things are going. And you overhear this group of nurses talking about stress in the workplace, how exhausted they are, how frustrated they are. And you hear one of the nurses say that she will never have her son or daughter consider a career in medicine, never, because of everything that she's experienced. How do you interpret that? How do you internally analyze that as an administrator? Would you really have faith that, this nurse who works for your facility is supposed to be here to take care of your patients, but because of the level of stress, the level of burnout, the level of exhaustion that she's experiencing and frustration, would you have faith that she could devote her full attention to administering care for your patients that are in your facility? Whether you hear conversations like this or not, your clinical staff, your physicians, your nurses, your other medical professionals, they're going to be reporting kind of widespread job dissatisfaction and burnout. And we even have a report as late as 2015 from a company called Medscape, who come out and reported that about 46% of physicians, when they did this survey regarding burnout, and now this is specific to physicians, but they had about 46% response saying they had feelings of burnout, which when you look to the last time they did this survey in 2013, that was a huge jump. Because it was about 39% in 2013. So as a result of this, we see almost a 10% increase. And as a result, we see a lot of fewer physicians and fewer nurses who are really choosing to stay in healthcare just because of a couple of things we've already talked about. Mainly the increasing demand with the decreasing supply is really starting to affect our team members. So we said, physician-reported burnout. We'll focus on physicians here first, and then we'll move into focusing on nurses and other clinical staff. But we had a report saying that physicians experience burnout. About 46% were saying that. But let's look at why. So there's a couple causes as to why. The increasing paperwork. Hopefully all physicians get into healthcare and get into being a physician because they want to help people. But the amount of paperwork that's increasing, it seems almost daily, is really taking away from their productive time. They're not able to spend time with their patients. They're having to take time away from their family, their personal time. They're not getting that work-life balance like they need to. And then the increasing, coding requirements. We've talked about meaningful use in other classes, patient noncompliance, controlled substance issues. All these different policies and rule changes are really starting to weigh on our physicians. And when we look at a couple other causes too, hopefully you've heard about this in some of your other classes, but we'll review over it again real quick. Is something called the Dr. Oz effect, where patients are starting to self-diagnose because we have access to things like WebMD or Google, and we can go on and, kind of put in our symptoms, and it gives us a report back on maybe what's wrong with us. And so patients are starting to go in, well-intentioned, I'm sure, but going into the physician's office, they've already self-diagnosed themselves. They've already decided that they need this particular medication. And oftentimes when they get their mindset on what's wrong with them, it's hard to change it. So hard to change their mind. So it's making the physician's job even more difficult. Liability issues is another big one that is starting to turn a lot of physicians away from the healthcare field. And then just the ever-increasing electronic nature of healthcare. So we know that we're going more and more electronic, which can be a great thing. And to, some disciplines, administrators, maybe more corporate positions, this may seem like a very great, efficient thing. But we need to step back and put ourselves in the mind or the shoes of our clinical staff as well. And so the Mayo Clinic has come out with a report saying that there is a definite link when they've accounted for, all these controlling factors from age to specialty to the number of hours a week that physicians work. They found this very strong link between physician burnout and the time they're spending doing this digital work. So we have nearly, about half of our physicians, 44%, are saying that they're spending an unreasonable amount of time on these, what they consider more clerical tasks. They want to be with their patients. They want to be at the bedside with their patients. That's why they got into healthcare in the first place, hopefully. And having to work with these electronic medical records, and work within all these systems is really taking time away from their patients. And, we even had, like I said, 44% saying that they're dissatisfied with electronic health records because sometimes they're very cumbersome. You have a lot of boxes that you have to check and they take a little while to get through. And even 63% of doctors and physicians reporting that EMRs and EHRs have even made their jobs less efficient. When we were hoping the opposite would be true, that their jobs would be more streamlined and become more efficient so that they could get through and spend more time with their patients. But physicians, unfortunately, are reporting the opposite. So let's take a look at our nursing staff. So we've talked about, all the different reasons for burnout from a physician perspective. Now let's take a look at our probably our biggest component of the workforce, the nursing staff. Nurses, unfortunately, we see a lot of different things that sometimes even go beyond burnout with our nurses, and it's mainly due, depending on what discipline you're in, mainly due to the intense nature of their work and what they have to see, what they have to come into contact with every day. We tend to associate PTSD with veterans and military personnel, but understand too that your clinical staff, and again, depending on what discipline they're in, mainly you're going to see this more in your critical care, emergency services, nurses, but they're going to experience PTSD. You're going to have nurses that experience signs and symptoms of PTSD. And why is that? Think about everything they have to see on a daily basis, especially those that work in the emergency department or your first responders, your paramedics, EMTs, your flight nurses. Think about everything that they have to experience or everything they see every day that comes through their door. So we have about, at the last survey, 14% showing PTSD, and we have 86% of our ED nurses, 86% of our ED nurses showing compassion fatigue. And that's going to kind of snowball out, unfortunately, into our patient satisfaction scores. But this is a big deal, having 86%, almost our entire ED workforce, experiencing compassion fatigue. And think about, how many of those experiencing PTSD, anxiety, depression, and things like that. And, we really need to dig into the cause from an administrative standpoint so that we can understand how to start correcting a couple of these things or what we can do to mitigate some of this. Why is it? Why is it we see things like this? And there's a couple different points as to why we see things like this. So we know nurses work long shifts. A typical shift for a nurse in an acute care facility is 12 hours, but often, I can speak from personal experience, often that is not the case. Nurses typically end up working 13, 14, 15, sometimes 16 hours in a row. Their job is very demanding. We have a lot of shortage, as we talked about at the beginning of this module, with nurses, so we have a lot of short staff. So nurses are having to cover extra shifts. They're putting others first instead of themselves. So they're neglecting, they're neglecting relationships with their family. They're not getting work-life balance like we need them to have. And they're, working long hours. Like I said, sometimes shifts can last up to 16 hours. A nurse working in the ED for 16 hours, can you even imagine? And that's going to lead out to them neglecting even their own well-being. They're not taking care of themselves. And just, dealing with, the ins and outs of environments like the emergency department every day, the emotional baggage, the grief. They deal with a lot of sickness, a lot of death, a lot of families, a lot of violence. They see pretty much the gamut in the emergency department. And that can be very emotionally taxing for a nurse. So you couple all these things together, long shifts, nurse works 16-hour shifts, then has to come back in the next day for another 12-hour shift. They're not getting the sleep, the nutrition they probably need. They're not getting the relationships with their families and friends that they need because they're having to pick up for short staff or shifts on the schedule that are not covered. And then seeing, sickness and death and, violence day in and day out is very emotionally taxing. So how do we kind of relate this to what effect it's going to have out onto our patients? Between what we see with physicians and what we see with nursing staff, out onto patients, we're going to see lower satisfaction scores. We're going to see the likelihood rises dramatically for an increase in infections for our patients. And then, think about the nurse, like we said just a few minutes ago, the nurse that's worked a 16-hour shift. How cognitively aware can you be after being up and awake and working in a demanding environment like that for 16 hours? How likely are you to make an error? Or how likely do you think it is that an error will be made? And it's kind of this, cycle of just, bad things happening. So you have nurses with decreased job satisfaction. They're going to get burned out. We're going to turn nurses over, which we know costs us about $70,000. With the turnover, it takes about 90 days to fill a position. So we're going to have shortage. We're going to have inadequate staffing because of that shortage. And it's just going to be this vicious cycle that keeps going around and around and around, affecting our patients. So it's just something that I want you guys to be aware of. Now we'll look to, burnout is not specific just to our clinical staff. We have a lot of administrative burnout and a lot of administrative turnover. In 2015, we had almost 20% of hospital CEOs turnover, which is the highest rate we can see here on the bar chart on the right over the past 2 decades almost. So look, even in 2013, we had 20% turnover, and it's been pretty level since 2013. But think about the things that were going on. So we are leaving 2010 when ACA is enacted. We see it kind of level into the next year, increase. We start seeing regulations and different rules and policies start to go into place. Highest rate at 2013 was 20%, and then it stays consistent at about 18% throughout 2015. And I wanted to put this kind of quote here at the bottom, because this is probably the truest thing that I've ever read about people in an administrative position, particularly with hospital CEOs, and I've seen this happen. We said probably one of the most important things at a facility with an organization is the culture. Nothing can succeed or nothing can survive without a culture in place that supports, change, supports success, things like that. But the culture cannot be sustained with constant turnover. Every 3 to 4 years, we're seeing hospital CEOs turn over, and unfortunately, people are being kind of put in these positions, and you have this short amount of time, about 3 to 4 years, to kind of prove yourself, and it's really sink or swim, which causes a lot of what we're seeing here with this hospital CEO burnout. So just a couple things to think about, and we'll talk about a couple reasons. We've already mentioned some already, such as reform implementation, new care models, but a big one is this trend of consolidation. So we're starting to see a lot more mergers and acquisitions, or as we have these smaller hospital CEOs being absorbed by bigger hospitals, these CEOs are just either not equipped with the right tools to work in these larger systems, or they simply just don't want to work in a larger hospital or a larger health system. They want to stay with their smaller community hospitals. Retirement is affecting CEOs as well, and then they're not without being affected by increasing demand. So they're starting to oversee all operations in this really rapidly changing environment that we find ourselves in with healthcare. So how do we kind of start to think from an administrative standpoint how to manage or how to get our teams through periods and episodes of burnout, turnover, all these different things that we can see? How can we kind of start to mitigate some of these different causes that we've talked about from the physician standpoint, the nurse's standpoint, and the CEO standpoint? Well, you're familiar, hopefully, with the triple aim. We know that triple aim is improving healthcare, making it patient-centered, and reducing costs. But really, there is a key component missing here. This triple aim is great, but we're missing the focus on one thing, which would make it the quadruple aim, and that's really bringing the joy of practicing medicine and being in the healthcare environment back to being in medicine. It's been made such a bureaucratic mess that, as we can see from the previous slides, it's just sometimes unenjoyable to be in. So we need to kind of bring focus to what's been being called the quadruple aim. Humanizing healthcare for all and improving quality, safety, and driving loyalty and growth. How do we ensure that we focus on initiatives that work to prevent burnout for our care team members? And there's a couple different good texts out there that cover this topic. One, it was your assigned reading for this module, and it's an excerpt out of a book called The Patient Comes Second, which I know sounds really crazy, because you've been told probably since you've been in college, or if you work in the workforce right now, since you've been in the workforce, that the patient always comes first. But there's a great book out there called The Patient Comes Second. They make a good point. Focusing on employee engagement is akin to being on an airline and putting your oxygen mask on first before attending to your kids. So think about that scenario. If you fly, or if you've ever flown, they tell you to put your own mask on first before assisting others. It's the same way here in the relationship between our patients and our team members or our clinical staff. How can we help our patients when our clinical staff is suffering? So the first thing we need to do is really identify what is leading to burnout and fatigue and really work to remove them. So facilitate an understanding, bring some small groups together, discuss stresses and how can we kind of help each other. Team huddles are one that's growing in popularity. So if you invest 3 minutes a day into your staff, bring them together, kind of troubleshoot a couple issues, do some root cause problem solving. This is where we can bring quality back into the mix. There may be little things that are working to be built into bigger things that we can probably stop when they're little. And these 3-minute huddle a days are a perfect opportunity to do that. And it gives you as an administrator, as a manager, that opportunity to ask, how are you doing and how are things going? And external stressors, people have lives outside of work. and they've got a lot of things that can be stressing them, not just work. You're gonna need to provide resources, or it would be a good idea or behoove you as an administrator or a manager to provide resources to your staff to kind of help alleviate some of what can be these external stressors. And an example of this is to do something called an employee lunch and learn. Go out, buy some pizzas or buy some subs, sit around, bring a professional in that knows something about finance. Money is a big stressor for a lot of people. And so you can bring somebody in that can help with personal finance and kind of how to get them on a budget. What about preparing healthy meals? We can bring some pastoral care representatives in to do some meditation, to pray with you. Really the secret to offering great patient care is giving care to our caregivers first and taking care of our caregivers, and that's going to have a domino effect out onto our patients. The other big trend we see starting to emerge is something called the CXO, the Chief Experience Officer. And this person is in charge of exactly what their role says. They are in charge of the experience that the patient and the team member has at the organization. So they're responsible for kind of bringing together and tying together quality, safety, to move us to improved care delivery. So how do we engage clinicians and patients and family and bring this patient-centered care together and make us all equal partners, and how do we kind of drive that transformation? So I'm not going to go over this in depth. This is available to you on the D2L site, so I want you to make sure, if you have to, go ahead and pause the video here. But I want you to go read this case study from the IHI about a physician named Anna. And think about a couple of these questions, and I'll scroll through them as I'm talking, but think about a couple of these questions. And how would you answer them? Especially this one, what role did culture play in this particular situation, and how would you handle this as a manager or as an administrator? Now, in regards to the case study, these are a couple things that I always bring up, particularly around preventing burnout, and these are things that we've talked about before. What's your leave of absence policy, sabbatical programs, flexible scheduling. Mentorship is a huge one. Nobody likes to be thrown in the middle of the mix without knowing what they're doing. And so mentorship can be more beneficial than you probably realize or understand. So to finish with a couple key points, we need to start planning now how we're going to address our workforce shortage and kind of how we're going to deal with that. And part of that can be helped by remembering not only the triple aim, but now moving to more of what's being termed the quadruple aim. And just being aware of maybe some resources that can alleviate different symptoms of burnout and hopefully decrease some shortage that you see out there. So next time we're going to talk about care in the palm of your hand. We're going to talk about the electronic nature of healthcare. But as for workforce shortage and burnout, please make sure to go view that case study or read through that case study. And this is all I have. Thank you.